Hello everyone, this is Malarvizhi, Assistant Professor, Department of Medical Surgical Nursing from ES College of Nursing. This presentation about us ascites. First, introduction of ascites. Ascites is a cavity. Normally contains approximately 50 to 75 ml of fluids that serves to lubricate the tissues that line the abdominal walls and viscera. The term ascites is reserved to denote an abnormal accumulation of these fluids. It is derived from the Greek words ascos means bag or sac. Mesothelium cells of the peritoneum produce the peritoneal fluids. It increases the pressures in the portal vein, causes large vein varices to develop across the esophagus and stomach to get around the blockage. The varices become fragile and can bleed easily. Next, definition of ascites. Ascites, it is the accumulation of fluids in the peritoneal cavity, serous membranes which covers the abdominal organs. Ascite is defined as accumulation of more than 25 ml of fluids in the peritoneal cavity. Ascites is abnormal intraperitoneal accumulation of watery fluid containing a small amount of proteins. Next, causes. In general, specific liver disease like a cirrhosis, it 80% if the patients are chronically intake of alcohol. In veno-occlusive disease and heart disease and congestive heart failure, in congestive heart failure, the heart is cannot pump enough blood to meet your body. In constrictive pericarditis, it is a malignant. It is a disorder of malignancy disease. It is a inflammations of the pericardium, that is a thickening and difficult to pumping of blood through the body. And liver cancer, that is a cancerous, it will be the cancerous cells, it will be spread to the liver tissues. In ovarian cancers, that is a cancerous, the cancerous cell, it will be present in the ovary and then fallopian tube. In peritoneal metastasis and pancreatic cancer, hypoalbuminemia. In hypoalbuminemia, it is a low albumin level, it will be observed. Then nephrotic syndrome. Nephrotic syndrome is a primary disorder. It will be leads to a decreased hypoalbuminemia, increased hypoproteinemia, and then increased hypercholesteremia. The proteins losing a entropathy. The protein loss entropathy, it is a decreased absorptions of the proteins in the GI tract and difficult to absorb of proteins. In malnutrition, it malnutritions like a deficiency of proteins and vitamins and minerals also. In general, specific hepatic vein obstruction and Budd-Chiari syndrome, it is a chronic inflammatory conditions. Pancreatitis, it is an infection and inflammations of the pancreas. Appendicitis, it is infection and inflammations of the appendix. And infective peritonitis, that is the inflammations of the peritoneum. Types of ascites. Transitate. In transitate, it is a fluid built up caused by a systemic conditions that alter the pressures in blood vessels, causing fluids to leave the vascular system. That is called as a transitate. In cirrhosis, it 81% of alcoholic, in 65% in viral infection, in 10% and cryptogenic in 6%. In heart failure, 3%. In hepatic venous occlusion, it is the second type of ascites. It is a Budd-Chiari syndrome or venous occlusive disease. Okay, in venous occlusive disease, it is that will be affecting to your liver and blood vessels also. It constrictive pericarditis, it is the inflammations of the pericardium, and squashiaker, This kwashiorkor childhood protein energy malnutrition causes of a high serum ascites, albumin gradients and transitate. And exudate is a fluid built up caused by a tissue leakage due to inflammation or local cellular damage. The causes of low serum ascites, albumin gradients or exudates are cancer metastasis and primary peritoneal carcinomatosis. It is a 10%. And next one is the infection. Tuberculosis. The tuberculosis, Mycobacterium tuberculosis, the 2% are spontaneously affected with the peritonitis. In peritonitis, some of the bacteria will be enter into the peritoneum. In pancreatitis, 1%, serositis, infection and inflammations of the serous tissue. In nephrotic syndrome and clinical manifestations. In clinical manifestations, what are the symptoms present like a increased abdominal girth because of the fluid will be accumulations in the peritoneal cavity. That's time they will be increase the abdominal girth, rapid weight gain, shortness of breath, difficult to breathing, uncomfortable. The patients feel uncomfortable, umbilical hernia, abnormal protrusions of the internal organs, fluids and electrolytes imbalance. Then fatigue, bloating, nausea and vomiting, decreased appetite, abdominal pain, back pain, constipation, frequently passing of urination, heartburn and edema. In diagnostic evaluation, history collection and physical examination. In history collection, they have to collect the all history from the patient. In physical examination, in particularly you have to focus on the abdomen because of the fluid will be accumulations in the peritoneal cavity, and they have to check the abdominal girth also. In clinical size, like you have to inspections of the abdomen like a flank fullness or massive ascites. In percussion, in Budal signs, minimum the fluid up to 150 ml, shifting dullness and moderate amount of fluids up to 500 ml. The fluid thrill, massive amount of fluid up to 1000 to 1500 ml. In Budal signs, make the patient's client sit in knee-elbow position and pressures at the point of maximum prominence of lax abdominal bundle. The elicitations of dull notes suggest the presence of fluids. And fluid thrill sound, make the patients lie comfortably on the couch. Ask another person to place the edge of the palm in the midline to stabilize the abdominal fat and wall. Place the palm of one hand on the opposite sides of the abdominal. Flick the skin on the side of abdominal. Diagnostic findings. In what are the diagnostic evaluations they have to taken like a blood test, liver function test, percussions, ultrasound of the abdomen and CT scan of abdominal, chest and abdominal x-ray they have to taken, and paracentesis. In paracentesis, a small catheter will be inserted into the peritoneal cavity and they will be collect the fluids. In complications of ascites is spontaneously bacterial peritonitis. It means that the spontaneously bacteria will be enter into the peritoneum. And the abdominal wall hernias, they will be internal organ protrusion and pleural effusions, accumulation of fluids in the pleural space, and bloody ascites will be accumulated in the peritoneum. Then management. In medical management, we will start the pharmacological treatments. First we will start the diuretics like a furosemide, it aldosterone antagonist and spironolactone, and ammonium chloride and acetazolamide diamox are contraindicated because of the possibility of precipitating a hepatic coma. Hepatic coma, it is a metabolic disorder. The damage to the brain. Transitive ascites. In transitive ascites, restrictions of sodium and water intake and promoting urine output with diuretics, and it is necessary removing ascites directly by the paracentesis. Next, nursing management, peritovenous shunt. The peritovenous shunt, Leven shunt, is a shunt which drain the peritoneal fluid from the peritoneum into the veins, usually the intrajugular vein or the superior vena cava. Transjugular, intrahepatic and portosystemic shunt. The TIPS is an artificial channel between the liver that establishes communications between the inflow portal vein and the outflow hepatic vein. It is used to treat portal hypertension, which frequently leads to intestinal bleeding. Next, non-pharmacological therapy, adequate bed rest, fluid management, as the patients with ascites along with the cirrhosis present with hyponatremia decrease the sodium level, and hypovolemia decrease the fluid volume. If the sodium level is less than 130 milliequivalent per liter, water restricted at least for 1.5 liters per day is recommended to the patient. In diet management, advice to the patient with ascites is advised to take low sodium diet, maintaining nutritional patterns in patients with ascites, and measure the height and weight along with the BMI. BMI is one of the methods to assess the nutritional status of patients with ascites. Measurements of weight. Measure the weight of the patients daily and they compare the findings with the previous finding. They will be compared with the before the days. If the patient is not able to move, provide the position to the patients every second hourly. In every second hour, they have to change the position of the patient. In nursing managements, assessments should be ongoing and precise. The pain should be assessed continuously and should be acute upon the GI functions. The GI function should be monitored to assess the response to intervention. And then fluids and electrolytes balance should be maintained.